Hello, everyone. My name is Brianna Prizer. I am not your teacher, but I am guest lecturing this week on behalf of your instructor, Ms. Meyer, and I'm going to be reviewing with you Chapter 6 of the textbook and talking about conducting research in clinical psychology. So I'm just going to start by sharing my screen so that we can go over the lecture slides together. Here we are. And it is worth noting as we're getting into this topic that um, research methods within clinical psychology do have considerable overlap with research methods across other disciplines. And so some of this information may be review from other courses if you've taken a research methods class. And it's still important to go over it within the context of clinical psychology because some of the terminology is different and some of the terms require a little bit different focus or consideration when they are considered within the context of clinical psychology. And so we'll start with the question of why do clinical psychologists do research? And they do it for a whole multitude of reasons. But first and foremost, the most fundamental reason is to gain knowledge about psychological disorders. And so research in clinical psychology can help us answer questions like, is social anxiety experienced differently by men versus women? And so we know from research in clinical psychology that women are more likely to experience social anxiety than men are, but even within groups of men and women that are diagnosed with social anxiety, women experience more severe symptoms. They experience more distress related to their social anxiety, and then the comorbidities of men and women are different as well. So, women with social anxiety are more likely to also experience comorbid generalized anxiety disorder or PTSD, where men are more likely to experience conduct disorder or substance abuse problems. And so, this would be basic knowledge of psychological disorders and how they differ on this one factor, which is sex or gender differences. The second reason why clinical psychologists do research is to understand how well therapies work and who they work for. And this is something that we'll get into a little bit later on in the lecture, but your book does a really good job of discussing this point in a box called Considering Culture. And so I'd urge you to read that in chapter 6 of the text. Another psychotherapy related Another psychotherapy related type of research that clinical psychologists do is on something called dissemination strategies. And so this is spreading information on therapies that we already know work to a large number of therapists that then can provide those therapies and implement those therapies for the people who we know need them. Because doing all of the research and finding out what works well is only the first step. Then we need to get that information out to the providers that are actually providing those treatments or those services to individuals. Clinical psychologists also do research in order to evaluate and improve assessment methods that are used with clients. And so studies that would fall under this bullet point here may involve developing or validating new measures, expanding the use of measures to different client populations, establishing normative data for specific populations for an assessment tool, or comparing multiple assessment tools to see which work best or how they compare to one another. Clinical psychologists, researchers also conduct research to explore issues of diagnosis and categorization of psychological problems. And so studies falling under this umbrella here may examine validity or reliability of existing diagnostic constructs, the relationship between disorders, prevalence or course of disorders over time, or other kind of related topics. So one example that would fall under this is an example from your book that talks about a group of researchers that were conducting a review of studies on the relationship between eating disorders and personality disorders. And an interesting finding that they had was that there was considerable overlap between anorexia nervosa, which is an eating disorder, and obsessive compulsive personality, such that individuals that were predisposed to one were also then predisposed to the other. And so that would be getting at the relationships between the disorders and comorbidities. Clinical psychologists will also examine elements of their own profession through empirical research. And so they'll study other clinical psychologists' activities or beliefs or practices, among other aspects of their professional lives. And so something else that's important that would fall under this bullet point here is ethical dilemmas that happen within therapy, which would be important to study and to understand better. And then lastly, clinical psychologists also pursue research questions related to how to train and educate the next generation of psychologists that are entering the profession. And so these areas of study could include training philosophy, specific coursework, opportunities for specialized training, or the outcome of particular training efforts. So one example of this is how to best train students to write assessment reports so that the assessment report that goes out across clinical psychologists conforms to a specific template in terms of reporting on themes rather than reporting on each test individually, how to increase readability, and doing this research and finding out what most participants saw was most readable in those assessment reports then can guide training efforts for clinical psychologists, training younger clinical psychologists to create the most comprehensive or most effective way to write those assessment reports. Okay, and then before we move into specific research methods or the ways in which clinical psychologist researchers conduct that research, it's helpful just to do a little review of what we mean when we say evidence-based practice. And so the definition of evidence-based practice is the integration of the best available research with clinical expertise in the context of patient characteristics, culture, and of preferences. So evidence-based practice relies on and is supported by these three foundations. Okay. So in talking about research in clinical psychology, it's important to distinguish studies of psychotherapy outcome research that measure the efficacy versus those that measure the effectiveness. So let's talk about what each of those mean individually, how they're the same, how they're different. So efficacy is referring to the success of a particular therapy in a controlled study that's conducted with clients who are chosen according to specific study criteria. And so essentially, it's how well a form of therapy works in the lab, because it's practiced according to manualized methods where the outcome for treated individuals is compared via clinical trial, or comparing the outcome of a clinical trial versus of a no treatment group. And so participants are often selected on the basis of meeting very strict criteria, often diagnostic criteria, and then are randomly assigned to either the treatment or control group. And in many cases, more than half of those that are interested in participating actually end up being excluded and are not a part of the research study. And so those who are included are typically less severe. They have textbook examples of disorders without kind of a lot of comorbidities clouding the picture. And they're less likely to be from minority populations than when you compare clients in actual clinical settings. And you can imagine that this would cause all sorts of problems when the treatments then leave the lab and don't work as well for different kinds of people. And so this is where that considering culture box comes back in. And so it does have an in-depth discussion of this point more specifically on kind of the trade-off there between controlling for a lot of extraneous factors and then accidentally leaving some people out. But largely, when psychotherapy outcome researchers are designing an efficacy study, what they're trying to do is minimize any other factors that may bring into question the causal connection between the treatment and that outcome. And so it's bolstering the study's internal validity, but it's limiting the generalizability or the external validity. And what we actually find is that it's a trade-off. The stronger you get in one, the weaker you get in the other. So then switching and looking alternatively at what an effectiveness study is it's the success of a therapy in an actual clinical setting in which the client's problems span a wider range and the clients aren't chosen as a result of meeting a specific diagnostic criteria. And so the effectiveness of a psychotherapy then is how well it works in the real world. or how well it's translating from the lab to the clinic or a hospital or another clinical setting in which a clinical psychologist might operate. So then opposing or opposite of an efficacy study, the effectiveness studies are respected for their external validity and then discounted for their internal validity. And whether or not we're choosing to prioritize one versus the other is going to depend on that specific research question. And the last important note that I want to make here in discussing efficacy versus effectiveness is and in measuring therapy outcomes more generally, is how important it is in order to distinguish a statistical significance from a clinical significance when we're interpreting the results of a treatment outcome study. And so what do I mean by this? When we look at statistical significance, what that's telling us is, yes, there is this significant difference that's existing between the two groups, and the two groups would be the experimental treatment group or the control group that didn't receive treatment. But just because that difference exists doesn't necessarily mean that it has a real world implication for those people. And so to illustrate this with an example, if we looked at a study of participants that were coming to receive treatment for depression, and their depression symptom score at the start of the study was an 80 out of 100. That would be for both groups. And what that would translate to is pretty significant, severe, and impairing depression for those individuals. And then the groups are split up. Half of the people receive a treatment and half of the people don't receive the treatment. And the people that do receive the treatment go from an 80 to a 75. And the people that don't receive the treatment stay at an 80. So what a statistical test would tell us is, yes, there is a 5-point difference, and it's there. That difference is attributable to the effect of the treatment. The problem is that when we're talking about on a scale of 100, there isn't a clinical significance for those participants because their quality of life and their depression symptom severity overall is still pretty bad, and it's still pretty similar. So there wouldn't be a clinically significant difference, even if the statistically significant difference was present. And so for that reason, when we talk about therapy outcome research, we want to be reporting both on statistical significance and clinical significance. All right, so next we're going to talk about how clinical psychologists do research, and we'll start just by briefly going over what the experimental method is. And so, like many other scientists, clinical psychologist researchers are conforming to the experimental method, which is just a sequence of steps that begins with an observation of events. And then we develop a hypothesis to try to explain the events that we're observing. And that step would then include defining what our independent variables are, what are the ones that we're going to manipulate, what are we going to change, what's the treatment, what's the active ingredient, and what are the dependent variables, what are the things that we're hoping to change as a result of the change in the independent variable. A lot of times in treatment research, that would be a reduction in symptoms. After that step, after the hypothesis developed, we would test those hypotheses empirically. And then finally, once testing is complete, we would alter the hypothesis for the next study in order to match the results and interpretations that were obtained during that empirical testing. And so the experimental method is constantly evolving and updating to include new findings from the previous study. So one type of experimental study that is more specific to clinical psychology is randomized clinical trials, or RCTs. And these are considered the gold standard for determining if a practice or a treatment is evidence-based. They're considered the gold standard because they're maximizing internal validity by controlling for other variables and ensuring that improvements in participants that are receiving the therapy are indeed due to the therapy instead of due to something else. And so in this highly controlled environment, a randomized clinical trial or randomized control trial is beginning with recruitment and selecting participants who meet a very strict criteria or meet a standard diagnosis. And then each participant is randomly assigned to a group that either receives the treatment or doesn't receive the treatment. And participants that are in the control group, they may receive no treatment, they may be placed on a waitlist control group where they receive the treatment after the study, or they may receive a placebo or non-specific treatment, or they may receive a standard or kind of routine treatment that doesn't have the active ingredient that we're testing with the study. And in both groups, the target variables are typically objective measures of self-reported symptoms, and they're assessed at the beginning and then at the end. And that comparison between the two groups indicates the degree to which that treatment was helpful. I did accidentally skip this point though, which is about what variables are harder to control. And so some things that are hard to control, even when we look at the experimental versus control group, is something like therapist effects or common factors across therapy, such as the therapy environment being a supportive place that can foster change or support just by being in that environment. Similarly, a placebo effect for the participant themselves, just having any kind of engagement could lead to like hope for change for the future, or patient or participant expectations for treatment, which can also impact the outcomes as well. And so on one hand, these RCTs are praised for increasing scientific rigor of therapy outcome studies. And then on the other hand, they're criticized for oversimplifying clinical problems by reducing them to objective and easily measurable symptoms, and then for producing results that don't always translate well to real world settings. And so if we go back to our earlier terminology, an RCT is very good for demonstrating efficacy, but not always great for demonstrating or testing effectiveness of a treatment. So in considering other research designs, research in clinical psychology often involves variables that the researcher isn't able to entirely control. And that's for ethical reasons, for practical reasons, or for other reasons. Researchers are often limited in their ability to assign people randomly to certain conditions, or to make manipulations, or to otherwise experimentally test certain hypotheses. So as one illustrative example of this, if a group of clinical psychology researchers were interested in examining the outcome of a particular therapy for a specific phobia, or for specific phobias, in a true experiment, what the researcher would have to do is induce the same specific phobia in all of the participants and then randomly assign them to different treatment conditions to measure the influence of that treatment. Obviously, that's an ethical concern, and we're not able to induce specific phobias in research participants. That's not justifiable. It's doing harm. And so what the researchers may choose to do, if this was their research question, is to instead opt to use a quasi-experimental design, where they're acknowledging that the individuals in the two comparison groups are going to have different phobias, or going to have different intensities of fear or phobia to those feared objects, and that they'll also differ in other ways, like demographics or personality variables. And that's the case even if the researcher attempts to match on as many of those variables as possible. So the best that we can do in a quasi-experimental design is to measure these differences and then to try to control for that variation later on in the statistical analysis. And so quasi-experimental designs are technically less scientifically sound than the experimental designs like an RCT, but they are frequently used in clinical psychology and often yield very meaningful and important results when we can't use a true experimental design. Okay, so now we want to talk about cross-sectional versus longitudinal study designs. And really what we're talking about here is time. And so a cross-sectional study design is assessing or comparing a participant or a group in one particular point in time, whereas a longitudinal study design is emphasizing changes across time. So often making within group comparisons from one time point to another. So cross-sectional study designs tend to be easier and more efficient. And so that's a pro that they have over the longitudinal designs, which require much longer periods of time. However, the cross-sectional studies don't provide a valid approximation for a change that takes place or evolves over time, whereas a longitudinal study has the unique ability to do that. So for one example, if we choose something that's kind of complicated, like the relationship between mood and sleep, where we know that they co-occur and that they impact each other, such that poor sleep will lead to poor mood and poor mood will lead to poor sleep. So if we were to try to look at that relationship in a cross-sectional study design, all that we would be able to say is that they're happening at the same time, that that's that greater, more like better sleep would lead to lower mood symptoms or vice versa. However, if we did a longitudinal study design for this, what we would be able to track and measure is changes or evolution in sleep or mood over time, and how changes in one might then lead to an evolution or a change in the other as well. And so again, sounds like a little bit like a broken record, but again, what you would choose to do here on cross-sectional versus longitudinal study design, you would choose that based on what research question you have. Because if you don't care about the process of change, you could go with an easier and more efficient study design like a cross-sectional study design. And so this is actually a good stop for me to pause and to stop sharing. I'm going to pick back up with the second of 2 lectures for this topic. So I'll see you in the next video.